Okay guys, very good morning. As I promised you that today in YouTube session we'll discuss neurocognitive disorder. In neurocognitive disorder, it's a very important topic. Neurocognitive disorders is a current name. Previously, we were calling it organic disorder. Organic disorders. So the important points, in every exam, not a single exam is there where we, don't get the MCQ from the neurocognitive disorders. As usually in a lighter way, always I tell in classes that if dementia MCQ is not there, then paper is going to cancel. So that important this topic is. So currently we use the word in DSM-5 and ICD-11 neurocognitive disorder. Previously we were calling it organic disorder. First we'll discuss dementia. What important point you should know about dementia? Point number 1. What is dementia? Impairment of, guys, I request you, any queries you have, please ask. The more queries you will ask, more it will be, good interactive session. So please ask any queries you have. What is dementia? Impairment of higher mental functions. Impairment of higher mental function is dementia. Usually we say forgetfulness or memory loss, but it is not. It's an impairment of higher mental function. What is higher mental function? In mental state examination, we have one of the heading of mental state examination is higher mental function. And in higher mental function, we have consciousness, orientation, memory, intelligence, attention and concentration, abstract thinking. So it's an impairment of higher mental function. Dementia is a neurocognitive disorder, organic disorder, and one of the characteristic of organic disorder that patient, that there is an impairment of consciousness. But in dementia, there is no impairment of consciousness. No impairment of consciousness. Second important point. So there is no impairment of consciousness that they are asking. Till last, dementia patient never remain, there is no impairment of he is or she is fully conscious. In last stage of dementia, maybe there is a, superimposed delirium and patient can have problem, but otherwise there is no impairment of consciousness. Etiology. If they ask you, in etiology, in biochemical theory, three important points they can ask. Which is a main neurotransmitter? Decrease level of acetylcholine. Decrease level of acetylcholine. Or which enzyme decreases? Choline acetyl transferase. So decrease level of acetylcholine or choline acetyl transferase. There are two enzymes. One enzyme is responsible for synthesis, one enzyme is responsible for metabolism. Choline acetyl transferase is responsible for synthesis and acetylcholine esterase is responsible for metabolism. So either acetylcholine will decrease or they will say decrease level of enzyme which is responsible for synthesis, and that is choline acetyl transferase. Where they decrease? In nucleus basalis of Maynard. Where they decrease? nucleus basalis of Maynard. Nucleus basalis of Maynard. Apart from that, there is an increased level of glutamate and decreased level of norepinephrine. Norepinephrine decreases in locus ceruleus and glutamate increases in moderate to severe dementia. That you should know about the neurotransmitters. Genetics, which they ask very frequently. In genetics, we have late onset familial dementia, late onset familial and sporadic dementia, and early onset familial dementia. Okay, familial dementia. Before we were calling senile, pre-senile, this concept is gone now. Now we say late onset or early onset. Sometime if they ask, late onset means after 65 and early onset means before 65 years of age. Late onset familial dementia is two important genes are involved. ApoE gene. ApoE gene is associated with chromosome 19. ApoE gene is responsible for cholesterol metabolism. We have three variants of ApoE gene. ApoE2, which is more than E3, and that more than E4. That's a normal variant. After mutation, E4 become more than E2, and that's responsible for dysregulation of cholesterol metabolism and ultimately neurodegenerative disorder, dementia. Okay, but it has been seen that after ApoE gene mutation, only 50% patient develop dementia and 50% are not. So after mutation, only 50% develop the dementia, 50% not. It means dementia, only 50% develop the dementia, 50% not. It means ApoE gene mutation is neither sufficient nor necessary for development of dementia. This line you have to remember. Usually students know that okay, ApoE gene is involved in dementia. And suppose the examiner asks in exam that all of the following are true regarding dementia except. And if you answer, one of the option is given that ApoE gene mutation neither necessary nor sufficient. Usually student will think it's a wrong option because he knows that there is an involvement of ApoE gene. But actually you have to go in depth. That's why always we say that PG is about depth. PG is about concept. You should know the concept, you should know the depth properly. Even after mutation of ApoE gene, only 50% patient develop the dementia, 50% not. So you can conclude that ApoE gene mutation is neither sufficient nor necessary for development of late onset familial dementia. If it is the case, then what other gene is involved in a late onset familial dementia? And the other involvement is ubiquitin. Ubiquitin. Ubiquitin is what? Chromosome 9. Ubiquitin responsible for protein degradation. protein degradation. Correct? Ubiquitin is responsible for protein degradation. We have synthesis of protein, and that protein we have use for various function in body. When we have abnormal protein in our body, that abnormal protein is degraded by ubiquitin. But suppose we have problem in ubiquitin, then we are not able to degrade this abnormal protein in our body, and that abnormal protein get accumulated in our body and it is responsible for dementia. So ubiquitin chromosome 9 and apoegene chromosome 19 are associated with the late onset familial dementia. Early onset familial dementia, they are APP, amyloid precursor protein. Amyloid precursor protein. Presenilin 1 and presenilin 2. Presenilin 2. Amyloid precursor protein is associated with chromosome 21, presenilin 1 chromosome 14, presenilin 2 chromosome 1. We call it also PS1 and PS2. So amyloid precursor protein chromosome 21, presenilin 1 14, presenilin 2 1. 1, 14, 21 is associated with early onset familial dementia. 9 and 19 are associated with late onset familial dementia. This is genetics they ask. If guys they ask you about the diagnosis, I told you what is dementia. It's a impairment of higher mental function. In higher mental function, we have what? Consciousness, orientation, memory, attention and concentration, intelligence, abstract thinking. Usually about memory they ask the MCQ. One simple classification of memory that is what? Immediate memory, recent memory, remote memory. Immediate memory is up to 3 to 5 minutes, recent memory up to 7 days, and remote memory is more than 7 days. Okay. Immediate and recent memory store in hippocampus. Remote memory store in a neocortex. So immediate and recent memory is stored in a hippocampus, remote memory is stored in a neocortex. Immediate up to 3 to 5 minutes, recent up to 7 days, remote more than 7 days. Another important classification of memory we have that they are asking again and again, that I want to tell you properly. Explicit memory. Explicit memory and implicit memory. Explicit memory is a memory which we can express. We can express. That's why we call it also declarative memory. Declarative memory. Implicit memory is a memory which we can't express. We only can show through our skills. That's why we call it a non-declarative memory. Explicit memory You ask me, what's your name? What's your father name? Who was the first Prime Minister of India? Express. We can express it. We can declare it. So we call it a explicit. Also we call it a declarative. Explicit memory, guys. Processing of explicit memory occur in a hippocampal diencephalon system. Processing occur in a hippocampal diencephalon system. It is not present by birth. Explicit memory is not present by birth. By birth, nobody knows who is the Prime Minister, who is the President. So, processing occur in a hippocampal diencephalon system and it is not present by birth. We have two types of explicit memory. We have episodic and semantic. Episodic is about personal experience, what you have taken in breakfast, what you have done day before yesterday. And semantic memory is about facts, object and people. So personal experience, episodic, facts, object, people, semantic. Episodic memory deficit occur in amnestic syndrome. Deficit occur in amnestic syndrome. Semantic memory deficit occur in a Alzheimer disease. Alzheimer disease more in frontotemporal dementia. Frontotemporal dementia. That's very important. So, episodic memory is about personal experience, deficit in amnestic syndrome. Semantic memory is about general knowledge, about facts, about object, about people. Deficit occur in a Alzheimer disease, but more deficit, more particularly, semantic memory is for frontotemporal dementia. Frontotemporal dementia. Implicit memory. Implicit memory is processing in basal ganglia and cerebellum. Basal ganglia and cerebellum. It is implicit memory or non-declarative memory present by birth and operational through life. It's present by birth and operational through life. The big, sportsmen, Sachin Tendulkar, Virat Kohli, they are more organized, they are hardworking, they are talented, no doubt about that. But they also fortunate enough that they had some innate component of these skills. That's why they have a better acquired component. So this implicit memory, we have some innate part and some acquired part. So declarative or explicit memory is not present by birth, but implicit memory or non-declarative memory present by birth and operational through life. Processing in a basal ganglia and cerebellum. Implicit memory, the further subtypes of implicit or non-declarative. Procedural memory. Procedural memory is about skills. How to play cricket, how to drive a car, how to play badminton skills. Deficit occur in a subcortical dementia. Subcortical dementia. Apart from procedural, we have conditioning. We have conditioning in implicit memory. We have two types of conditioning. We have classical and operant. Classical conditioning was given by Pavlov, and operant conditioning was given by Skinner. So classical conditioning was given by Pavlov, operant conditioning was given by Skinner. In operant conditioning, we have further reinforcement and punishment. Okay, these techniques are very important for mentally retarded child, and we use it as a treatment strategy. Okay, classical Pavlov, operant Skinner. So procedural conditioning. Another subtype we have priming. In priming, what is priming? Exposure to one stimuli helps in a response to other. Like in PG, they have asked this MCQ, recent one of the entrance exam, that the EEG, the examiner or professor asked the student that who has given the EEG, electroencephalogram, and it was given by Hans Berger. A student doesn't remember, so the professor has given hint that what you eat in McDonald's, and in McDonald's you eat what? Burger. So this one, the burger stimulus is helping in a giving response about who has given the concept of EEG, Hans Berger. So this is a priming. Exposure to one stimuli helps in a response to other stimuli. This is priming. It comes under implicit or non-declarative memory. Also we have habituation. Habituation is continuous stimulus. If it is there, it get fed. Suppose you are every day preparing very well, but still I am every day scolding you in class. You work hard, second day I have to perform better, so sir should not scold me. Again you are preparing in a better way. Still I am scolding. And that process goes on. After one point of time, you will get tired. You will understand that whatever I am, preparation I am doing, sir is not understanding me, he is just scolding me. So you will be, okay with it. Okay, let's scold me, I don't care. This is kind of habituation. The continuous same stimuli get fed. This is a habituation. So procedural, conditioning, priming, habituation, they comes under implicit or non-declarative memory. Guys, this classification is very, very important. So please go through it. Okay. If we'll talk about pathology, we'll talk about pathology. We have macropathology and we have micropathology. In macro and micropathology. Macropathology, there's a diffuse cerebral atrophy. Diffuse cerebral atrophy. There is a atrophy of gyrus Because of atrophy of gyrus, widening of sulci, and because of widening of sulci, enlargement of third and fourth ventricles. Enlargement of third and fourth ventricles. So atrophy of gyrus, widening of sulci, enlargement of third and fourth ventricle. In micropathology, there is beta amyloid plaque and neurofibrillary tangles. Beta amyloid plaque, they are made up by beta pleated sheets, and neurofibrillary tangles, they are made up by tau protein. Okay guys, beta amyloid plaque is a extra cellular finding, and neurofibrillary tangle is a intracellular finding. These both findings are non-specific. Both findings are, so beta amyloid plaque, beta pleated sheets, neurofibrillary tangles, tau protein, neurofibrillary tangles intracellular, beta amyloid plaque extracellular, both are non-specific. It means if they are there, it doesn't mean patient only suffer from dementia. They can be a part of other disease as well. But if the examiner asks you that among these both, neurofibrillary tangle and beta amyloid plaque, which is more specific, your answer will be beta amyloid plaque. Beta amyloid plaque is more specific than neurofibrillary tangles. Beta amyloid plaque is more specific than neurofibrillary tangles. Guys, beta amyloid plaques, they might correlate with cognitive impairment. Neurofibrillary tangles correlates with duration and dementia severity. So beta amyloid plaque might correlate with cognitive impairment. Neurofibrillary tangles correlate with duration and dementia severity. That point you have to remember, that they are asking. Beta amyloid plaque might correlate with cognitive impairment. Neurofibrillary tangle correlate with dementia severity and duration. Okay. Neurofibrillary tangle is not pathognomic with Alzheimer's disease, but it is pathognomic for frontotemporal dementia. So it is not pathognomic. Neurofibril tangle is not pathognomic for Alzheimer's disease, but it is pathognomic for frontotemporal dementia. Very important lines. Neurofibril tangle correlate with dementia severity and duration. Beta amyloid plaque might correlate with cognitive impairment. These are the micro findings. Macro, there is a diffuse cerebral atrophy, enlargement of third and fourth ventricle. This is a classification of memory, explicit and implicit. Explicit is episodic semantic and implicit is procedural, conditioning, priming, habituation. Okay, and we have, guys, the apoegine and ubiquitin late onset, APP, PS1, PS2 early onset familial dementia. The main neurotransmitter is acetylcholine, which decreases in nucleus basalis of Maynard. Okay, and dementia is what? It's a impairment of higher mental function. Despite being an organic or neurocognitive disorder, there is no impairment of consciousness. Very important finding these are. Okay, so in this session, I think this was a very fruitful session. Please go through it. I hope you will love it. And once in next session, I will continue from here the part 2 neurocognitive disorder. There we will cover the rest part, the further treatment of dementias and the subtypes, and then delirium, Wernicke encephalopathy, and Korsakoff psychosis. Okay, guys. So I hope you liked it, and be ready for the next session and give your input also, that how we can further can take these YouTube sessions that can be more fruitful for you. Okay. Okay, guys. So have a great day. Bye bye. Love you all. God bless you. Study hard. Career is the most important friend of us. So don't miss this time. Most crucial time of your life. Best of luck, guys.